Okay, then I'll start now. Hmm. Can you guys see my screen? Can you guys see my screen? Yes? Okay. So today we'll be learning about chest X-rays, basically the views, the approach, and like some clinical stuff. So we know basically X-rays. They're wait, okay. Um, okay, so they're like a beam of photons, and the objects that are thicker they appear more white than the objects that are darker. And the longer the exposure is, the darker it appears. So okay, okay. And one second, one second. Okay, just one second. Okay, leave it. Okay. Uh, yeah, I will draw stuff. One second. Okay, fine, forget it. We'll just okay. So, what are the different views of chest X-ray that you guys know? Yeah. Anything else? I don't think we have oblique in chest X-ray. What is papilla? I haven't heard about papilla. Oh, okay. Okay. Okay, so there's PA view, AP view. Yeah, those are mammographs. Okay, PA view, AP view, lateral view. Then there is a decubitus view, which you take the patient is lying down on one side. Okay, and there's also something called lordotic view. Okay, and an expiration view. All right. So who makes them all? All right. Okay, so I'll just make this black now. No big deal. Okay, so PA view. In PA view, basically what we this is the X-ray that is generally taken as a routine. Okay, and what if the and we take this view PA view. If the patient is able to stand and is able to take a deep breath and hold it and is cooperative, like the patient is able to stand still, then uh, we usually prefer to take PA view. So what happens in PA view basically, the patient is standing against the plate with his front side against the plate, and the X-ray beams are directed from backwards, so from posteriorly to anteriorly. All right, and we make the patient take a deep breath, so the X-ray is taken under maximum inspiration. Okay, mm, and the in AP view we take it when a patient cannot. When a patient cannot stand or is not cooperative, the patient is sick, patient is in ICU, then we take an AP view. Usually, this machine is like a portable X-ray machine. Okay, it's a portable X-ray machine, and the patient will be lying down on the bed. And here, the plate is kept on behind the patient's. The plate is kept on the patient's back. Okay, so I don't know. Okay, I just got this from some YouTube video and I was not able to find a better picture. Okay, so the plate is kept at the patient's back. So the X-ray views are directed from the anteriorly to posteriorly. Okay, so this is the AP view. All right, and so why is APPA view preferred over AP view? That is basically because, like, if you played with shadows as a child, you know that, like, if you're casting a shadow on a wall, the closer you are to the screen where the shadow is being cast, there the smaller the object will appear, and as you go farther, the object will appear larger. All right, yeah. PA means posterior anterior view. Okay, so in posterior anterior view, the rays are directed from posteriorly to anteriorly. The plate is over here. Okay, so the rays are directed from posteriorly to anteriorly. That was the first one, PA view. In this, the patient is able to stand, take a deep breath, and then, like, basically, the patient's front side is against the plate. Okay, and the rays are coming from this side like this. Okay, and so that's how the X-ray is formed. In AP view, that is anterior posterior view, the X-rays come anteriorly and the plate is kept posteriorly. So like suppose if this is the screen, and if your hand is over here, okay, so if your hand is closer to the screen, like suppose like when you're making a shadow or something, okay, so if when your hand is so closer to the screen, the shadow appears smaller to more true to its size. If you move your hand away from the screen, the shadow becomes larger, like falsely larger. So that's why we prefer PA view, because in here, like the whatever we're taking, trying to capture the image of, it is more closer to the screen. In AP view, the heart is falsely enlarged. Okay. Okay. So this is an AP and a PA view. So which one is which? Can you guys tell? Which is PA view and which is AP view? Hello. Okay. Right is AP view. Yeah, that's correct. Yeah. Okay. Yeah, that's an easy thing to see. Like the heart is falsely enlarged, so it's AP view. That's one of the differences. What are the other differences between AP and PA view? Like, what are the other ways to differentiate between AP and PA view? Do you guys know? I don't know what lung inferior border. Yes, the ribs shadow. Okay, so basically in AP view, the anterior ribs will be more prominent, and in PA view, the posterior ribs will be more prominent. Okay, so here, these things that you see, those are the anterior ribs. They're less prominent. Okay, and these are the posterior ribs. Okay, they're more prominent. Okay, I'll talk about more about how to differentiate between the ribs later. And in this is PA view. Okay, okay, and this is AP view. In AP view, the anterior ribs are more prominent. All right. The second thing is the clavicles. In PA view, the clavicles are located more apically, like they're more on the apical side of the lungs. Okay, so the apical side is more like obscured by the clavicles. Whereas in AP view, the clavicles are visible more inferiorly. Okay, so the apices of the lungs are more clearly visible. Okay, and the second thing is the medial borders of the scapula, they are away from the lung fields. Like, they're over here. Okay, they're not touching the lung fields. Whereas in AP view, they kind of go into the lung fields. Okay, all right. So these are the things: clavicles, the scapula, and the ribs, and apparent cardiomegaly. All right. Yeah. Okay. So these inner borders of the scapula. Okay. Here they're kind of they're not projecting onto the lung fields. Okay. They're away from the lung fields. Like you cannot see them in the lung on the lung fields. Whereas over here, it's not clearly visible on this side. Okay. Like over here, you can see it's kind of projecting onto the lung fields. Okay. So that's the differentiation. In AP view, the middle border of the scapula kind of comes into the lung field. Can you see it on this side? Let me this thing coming onto over here. Last point, the AP, the clavicle point, the scapula point. See, in PA view, the scapula, yeah, this in PA view, this border of the scapula, it is not projecting, like it's not, see, it's located away from, this is the lung field, okay, and it's located away from it, okay, it's not projecting onto the lung field, it's not coming like this, okay, okay, but in AP view, if you see, this side is not so clearly visible, but this side it's more clearly visible. I mean, this side it's more, this side it's more clearly visible. Okay, so you can see this is the scapula over here. Okay, and it's kind of coming onto the lung field. Okay, whereas over here it's more towards the side. Did you guys understand? Yeah. Okay. Okay. Mm. So that is about AP and PA view. Okay, so next we'll go to the other views. This is the lateral view. So usually if you use a combination of PE view, posterior anterior view, and lateral view, you can like kind of see the pathology in a three-dimensional space. Like if it's like lateral view helps you to know if the pathology is anterior or more posterior. So that kind of helps to clearly localize the pathology. So in lateral view, the X-rays they're directed from the right side of the patient towards the left side. So the plate is kept towards the left side of the patient. Okay, and so that is it about lateral view, I think. And this is the lordotic view. So what is lordotic view is basically we use lordotic view to like visualize the apical regions better, okay, like more clearly to see if any there's if we suspect any pathology in the apical regions. So what we basically do is that suppose if this is the patient's chest, okay, and this is the plate, okay, where the X-ray is going to be formed. If usually the rays we try to make it perpendicular, okay, comes perpendicularly, okay, so then that's why the clavicles kind of project onto the apex. So in lordotic view, what we basically do is we project the X-rays at an angle like this. Okay, so that the apical view is more clearly visualized. Like everything else might be distorted in lordotic view, and it's more, but the apices of the lungs will be more clearly visualized. Okay, did you guys get that? Okay, yeah. All right. Then usually we try to take X-rays and maximally, like we ask the patient to maximally inspire when we're taking the X-ray. But in some cases, we prefer the patient to have to take the X-ray under expiration. Okay. Can you guys think of any situations in which we would like to take the X-ray in expiration view? No. Okay. So one of the cases is like if in case if we're suspecting foreign body aspiration, we do not want the patient to inspire and push the foreign body more inside. So we'd like to take an expiration view. Anything else? Yeah, even in pneumothorax, if we're suspecting a case of pneumothorax, then like if we ask the patient to inspire, we might miss like a small pneumothorax because we kind of get more air into the lungs. We'll not be able to differentiate it between what is an actual pneumothorax and what is the air the patient inspired. So we prefer to take an expiration view in pneumothorax as well. Okay. Okay, so this is basically to see diaphragm problems. I'm not sure about that. These are the two things that I saw, that I read about. Okay. Then, um, so approach to chest X-rays. Basically, if you see like different resources, everyone gives a different approach. Okay, and most of the places there was this ABCDEF thing, but also even in that, like the ABCDEF differs everywhere. So this one is what I thought was like the most, I don't know, useful, I guess. Okay, but the first thing when you're examining a chest X-ray, the first thing you'd like to do is to confirm that this X-ray is of the right patient. It is of the right date. Like, is it a pre-op or post-op chest X-ray? Okay, and if it's of some other body part, then if it's on the correct side, the correct view, all those things are important. Mm, okay, then you try to see if it's technically a good quality photo, a good quality X-ray. Okay, so we'll see what are the criteria for like having a good quality X-ray. Okay, and then we go through this ABCDEF to see if there's any pathology in any of these areas. So A is airway. We look at the trachea, the two bronchi, and then B is like the bones, which is basically the ribs, the clavicle, spine. Okay, and C is the cardiac silhouette. So we look at the cardiac shadow and the mediastinum. Where is it? Okay. Then diaphragm, and we look at the diaphragm and the gastric bubble. Then we see for any effusions like pleural effusion, pericardial effusions. Then F for lung fields. basically the lung areas, and then we look for any lines, any tubes, or any devices that are visible through the X-rays, and we try to identify them. Okay. Then, so for technical quality, we basically assess three things. So to see if an X-ray has a good quality, like technically, we see three things. The first one is rotation. We look if there is any unwanted rotation in the chest X-ray. The second thing is we if there is um, suboptimal inspiration, like if the patient has not maximally inspired. Okay, that is the second thing, suboptimal inspiration. And the third thing is like the contrast. If the X-ray is too bright or too dark, I think, like underexposed or overexposed. Okay, so we look for those three things. Okay, so first is rotation. Okay, so how do we see if there is any unwanted rotation in a chest X-ray? We basically see if the spinous process is in the midline and both the clavicles they're equidistant from the spinous process. Okay, like in this X-ray. All right, you guys able to see, right? Okay, what is the rotation of? Okay, so actually there is this thing. Hmm, yeah, so basically, suppose this is the patient. Okay, so there are many ways in this patient can actually be rotated. Okay, this patient can be rotated, um, like this patient can be rotated from side to side. Basically, like this part is more anterior and this part is more posterior. Okay, so that is basically the rotation that we actually talk about. Okay, this rotation, the meaning this side becoming more anterior and this side becoming more posterior. In that case, one side might look more larger than the other side. Okay, that is mainly the rotation that we talk about. In that case, is when the spinous process will not be in midline and it won't be equidistant from each other. But there can be other kinds of rotation also. Suppose if a patient is lying in bed, right? So if then the X-rays are not directed at an angle, it can become something like lordotic view. Okay, so even then there might be problems, but that is not what we usually talk about when we're talking about this rotation. All right. Um, and then the patient can just become like this, suppose. Okay, so even this rotation is not usually the rotation people talk about, but this is also a rotation that's possible. Okay, I mean, the X-ray will just be like that, and I think people just usually interpret it anyway. Okay. Then then we come to okay. So what are the consequences of rotation? Is basically like the cardiac silhouette and the lung fields. They'll just be like altered. Like you could not properly interpret them. Okay. Then we come to inadequate inspiration. So we ask the patient to, when we're taking a chest X-ray, we ask the patient to maximally inspire and hold their breath while the exposure is being done. Okay, so this allows the lungs to completely fill with air, and it allows the lung fields to be visible properly. Okay, so how do we check? How do we check that the patient had maximally inspired during the process? Okay, so basically you can see that the lungs will be fully expand first of all. Like you can see this thick line over here. That kind of means that the lungs has filled this whole area. Okay, this whole area. Okay, because both the pleura are touching each other. Okay, so this kind of shows that it is a maximally inspired film. Okay, and there are other things. Okay, so you're supposed to see at least 9 to 10 posterior ribs. Okay, at least 9 to 10 posterior ribs and 6 to 7 anterior ribs. All right, so if you're counting ribs over here, mm, this is like the first rib. Okay, posterior ribs. Okay, first rib, second, third, fourth, fifth, sixth, seventh, eight. Okay, nine. You can also actually see 10 over here. Okay, so 9 to 10. Okay, so that's like fine. Okay, 9 to 10 posterior ribs. All right, and then anterior ribs is these ones. Okay, these ones. So this is one. This is two. Two, three. This is PA view, yeah, because posterior ribs are more prominent. Posterior ribs are more horizontal, and anterior ribs are directed at a 45 degrees angle in PA view. Okay, okay. So one, two, three. This is four. I hope you guys can see. I'm not sure how it's visible. Four, 5. This is 6. Okay, and the seventh rib will mostly pierce the diaphragm. So this is the seventh rib. It's kind of like piercing the diaphragm. Okay, so this is a good quality, maximally inspired, good quality chest X-ray. Okay, I'll just erase everything so you guys can try counting as well. So you can see, even though you don't. Okay, can you see though? That's for real. Yeah. Okay. All right. Okay, so that is about maximally inspiration. So sometimes if the I'm yeah, okay. So this is like, see, you can see this is the same patient. Okay, this is like a not maximally inspired film. Okay, so you can only see 8 anterior ribs. Okay, and this is a maximally inspired rib. Okay, okay, okay. So okay. Okay, so guys, see here. So okay, so this is a film in which the patient has not maximally inspired. Okay, so only 8 ribs are visible, and the lung fields they kind of look more smaller. Okay, so if you look at this field, you might think there's some pathology, like maybe like the lung volumes are reduced or something is happening, like maybe there's some pleural effusion. But that is not actually true. That it's only because the patient is not maximally inspired. When the patient has maximally inspired, when the patient is maximally inspired, you're able to see all the like that. That's a normal film. All right. So the third thing is suboptimal penetration. So like a good quality film should not be like too bright or too dark. That depends on for how long the X-ray exposure was done, and what was the intensity of the X-rays and stuff. Okay, and if it's like too bright or too dark, we might miss certain pathologies or differences. Okay. All right. Okay, so now we'll come to like the approach. Okay, the ABCDEF. Okay, waiting. So the contrast is the last one. No, all of them are contrast, but different degrees of contrast. I mean, no, I think yeah. If too much contrast is put, then it'll be too dark, I guess. And so that is like the last one. But if the exposure is for long, then it appears not really clear with this thing. I think if you expose for really long, it appears more darker. If you expose for a short time, it appears more brighter. I have many X-rays of the middle one. Okay. Like basically the quality of the X-ray, yeah, like the contrast is basically the contrast between the black and white. Okay, so like this quality kind of thing, like the penetration, it kind of depends on for how long did you expose the X-rays. Also kind of on the build of the person, if the person was too obese or something. Okay, and like what was the intensity of the X-ray that was being shown. So based on that, it can either be too bright or there can be too much contrast. So if it's too bright, I mean, if it's too white, like you might miss certain pathologies, and if it's too dark, if it's yeah, if it's too dark, then you might not see something. All right. Okay. Then okay. What is KVA? Anyways. Oh, KVA. Okay, now I know. Okay, KV, I think. Okay, airways. So now coming to airways. So in airways, we see the trachea. Okay, and we see the right and left bronchi. Okay, let's try to see them over here. This is the trachea, a rectangular, slightly radiolucent thing in the midline. This is the trachea. Okay, and over here, if you follow the trachea down, you can kind of see it bifurcates over here. Not that clearly visible, but it's there. Okay, it bifurcates into two. Okay, So this is the trachea, this is the right bronchus, and this is the left bronchus, and the bifurcation of the two, you can see, can see. Yeah, if the bifurcation of the two bronchus is called the carina, okay, and so this is the carinal angle, CARINA, carina. Carinal angle is usually less than 90 degrees. If it's more than 90 degrees, then there's some pathology, okay. Okay, it's marked over here. Okay, think the next one also is marked. Okay, so you can see those two things. All right. Mm, okay, you guys understood. So what do we look for? Actually, what do we look for in these trachea and bronchi? We look for if there is any tracheal shift. Okay. If we look for if there is any deviation, and we look for, and we look if there is any stenosis. If there's any I don't know who's talking. Okay, look for if, and we see if there's any stenosis. Okay, so okay, let's just continue. Actually, yeah. Okay, so there's this X-ray. What do you guys see in this X-ray? P view. Which over there. What else?
Angle is more than 90.
Someone saying something on the mic? Yeah, there is a subglottic narrowing of the trachea over here. You guys can see. What is that thing called? It's called steeple sign. Yeah, yeah, acute tracheolaryngobronchitis. Yes, croup caused by parainfluenza viruses. Right. How do we treat it? How do we treat croup? Yeah, we give racemic epinephrine. What else?
क्या खा रही है तू? रोटी का चूर.
Hello, Born to Dream. Can you please switch off your mic? Thank you. Yeah, we give steroids too, and we give like cold mist inhalation. For mild cases, we give cold mist inhalation and steroids. In severe cases, we give cold mist inhalation, steroids, racemic epinephrine. Yeah, if it's too much, we can intubate. I don't know about bronchodilatation. I'm not sure. Yeah, we give humidified oxygen. Yeah, we give that. Okay. What is this? So, so the trachea can be deviated towards the side of the lesion and away from the side of the. Okay. Can you guys tell me in situations in which trachea is deviated towards the side of the lesion? Towards the side of the lesion. Yeah, in fibrosis. But yeah, I guess. Yeah, lung collapse. Okay, and away from the side of the lesion? Yes, pleural effusion, tension pneumothorax. Anything else which can um, do, like push the trachea to one side? Anything else? Anything else? In the mediastinum? Yeah, any mediastinal tumor can shift the trachea to one side, right? Okay, so now what is this? What is this? What do you think is this X? Lymphoma. Oh, okay, lymphoma can also shift, right? Yeah. What is this X-ray though? Yeah, goiter as well. fibrosis of so yeah, the trachea is like so basically there is fibrosis of the lung on the left side, and because of the fibrosis, the trachea is pulled towards that side. Okay, so that's why it looks like this. It's kind of deviated towards the left side. All right. There's some atelectasis also. Falcon just refers things to everybody else. Okay. Now, okay, so this this is a situation in which the carinal angle, which is the bifurcation of the trachea, is more than 90 degrees. Can you tell me some condition in which you'll see that this condition, the carinal angle will be more than 90 degrees? I don't know about pleural effusion. Maybe. Um, More obvious answers. I don't know actually if it's in mediastinitis or not. Yeah, yeah. Cardiomegaly. Which chamber of the heart more specifically? Can you guys guess which chamber of the heart more specifically? No, actually it's left atrial enlargement, but okay. We'll discuss this more in next class when we do cardiac. I just there are many other there are many other conditions in which if there's any mediastinal tumor over here, it can push these strip bronchi like this. And if left atrial appendage is enlarged, it can also. Yeah. Anyways, you can see there's this. What is this? Gonna remove all my scribblies. What is this? Mixoma. What is this? Is that a pacemaker? Joking. No, it's a prosthetic. It's a mitral valve. Okay, it's mitral valve. So this patient has had mitral valve replacement surgery. Okay. All right, all right. We'll just stop laughing and move on. Okay, guys. Wait, there was okay. I think it's coming. Anyways. Mm, yeah. So if it's deviated away from the affected side, it can be due to pneumothorax, proliferation, or large mass. If it's deviated towards the affected side, it can be due to atelectasis and fibrosis. And yeah, and then splaying, that is like increase in the 90-degree angle, can be due to extreme left atrial enlargement. Okay, what do you guys see in this X-ray? Okay, what do you guys see in this X-ray? Right bottom, very nice. Okay, I'm just gonna zoom in a bit so you guys can see clearly. Oh, voice cavities. It's like a D. X. Okay. What is that? What is okay. What do you guys see? Do you guys see something? This time. Yeah, something is still engulfed this time. We have to see. Bats is very close. There's some foreign body over here. I can't see what you guys are seeing though. I'm not sure what you guys are seeing. I can't see it. Okay, guys. Okay, guys, let's be serious now. What do you guys see over here? There's some foreign body in one of the bronchi. Okay, guys, what do you see here? There's some foreign body in one of the bronchi. Where? In the right bronchi, yes. Yes, yes. So things more commonly go in the right bronchi because it's vertical. So things are more um, likely to get lodged over there. But this is not a peanut. This is a. Can you guys see it? I'm going to just zoom in more. I don't think it's very visible. Is it visible? It's a tooth, actually. It's not a ring. It's a tooth. I don't know. It looks like a tooth. It's a tooth. All right. It's an adult X-ray. Adults won't like usually take in foreign objects, I guess. So, but tooths can go. Okay. Why am I laughing so much? Sorry for laughing so much. Anyways. Okay. Okay, now we go to bones. The next thing, so that is A. A is trachea and the two bronchi. You look for narrowing, you look for deviation, you look for any foreign body. Okay, that is A. Okay, so next you go to B, that is bones. All right, guys. Bones, we look at the ribs, the posterior ribs and the anterior ribs. The posterior ribs, they're more horizontal. Posterior ribs are more horizontal, so they're more easier to see. Okay, and the anterior ribs, they're kind of oriented at 45 degrees, and they're kind of more translucent. Okay, then we look at the clavicle. If there's any fracture or something, then we look at the each individual vertebrae. Okay, like you're able to see over here, these vertebrae, you can see them through the cardiac shadow in a good quality X-ray. You'll be able to see them through the cardiac shadow. So you can probably see if there's some infection or some thickening or some um, yeah. In bones, you look for any fractures, any rib fractures, any sclerotic or lytic lesions, and then any notched ribs. Can you tell me in which condition do you see notching of the ribs? Notching of the ribs basically means like this is this rib and it'll be like this. It'll go like this and it'll be like there'll be many notched ribs. Yes, coarctation of aorta. Right. Okay. Then you can look for any air in the mediastinum, any air in the subcutaneous tissues. Okay. So those are the things you basically see in like bones. Okay. Now this approach, like this ABCDEF approach, you kind of see that lungs come at the end. Like the lungs is basically lungs. So what this approach basically does, it makes you look at everything else before you look at the lungs. Normally when we look at the chest X-ray, we try to uh, look at the lungs the most. Okay. But in this approach, we make sure that we do not miss anything else. We do not miss any ribs fractures before we come and we look at the lungs specifically. Okay. Mm, okay, so the important thing is that you should know how to like you should know how to see which is the posterior rib and which is the anterior rib, and you should know how to count them. All right. Okay. Now, what is this? What do you guys see here? Yeah, but where? Where, right? Yes. Is there a term for this thing? This kind of fracture? Yeah, it's called flail chest. Okay, so basically, yeah, so basically, this rib over here is fractured. Okay, this rib over here is fractured, and this rib over here is fractured. Okay, can you guys see that? So if three contiguous ribs are fractured, like one portion of the thoracic cavity gets disconnected, like it does not move in coordination with the rest of the chest. So there's paradoxical motion of that chest upon breathing, okay? So it collapses inwards instead of going outwards, okay? So that is called flail chest. So it can lead to respiratory distress, tachypnea, and shadow breathing, okay? So that is basically what is flail chest, all right? You guys got that? Mhm. Okay, so next week, are you sure this is flail? I think so. I mean, that was the diagnosis when I chose it. Why do you not think this is flail though? Hmm? You have both sides. How could I not? It's there. It's very subtle, but it's there. Let me show you. Over here, this and this. Kind of very subtle, but it's there. Yeah, there are three ribs. You guys see clearly. Or is it one? Oh, two ribs should be broken at two places. That is the thing. Oh, then there's one over here. I'm not sure then. I thought it was okay. Okay, this one, this one, this is broken. I think over here. Okay. Yeah, it is also a clinical diagnosis, I think. But then, I'm not sure. Okay. Now going to the now going to the next one. So now we come to cardiac. We see in cardiac and we basically see the cardiac silhouette, okay, and all the mm, parts of the heart that they represent, and the mediastinum. Okay, so this is the aortic arch. Okay, this is the aortic arch. This is the left pulmonary artery. This side is the left atrium. Okay, left ventricle. Okay, then this is the right pulmonary artery. Okay, I think right atrium is this side. Okay, and right, yeah, this is basically the right atrium. Okay, and the descending aorta you can see, like actually I should be able to see over here. Somewhere over here is descending aorta. You can see. Ascending aorta you cannot see over here. Okay, the next image has it shown, so I'll just go to the next image now. I don't see any vessels. What does that mean? Anyways, okay, we'll go to the next one. Um, do I have? Okay, so are you guys understanding? I mean, are you guys able to see? It's basically like the border. Like this is the aortic arch. This is like the pulmonary artery. This whitish thing is what is the vessels. Like you cannot see it so clearly, but kind of like whitish. The vessel. Yeah. Okay. This is left atrium, left ventricle, right atrium. Some people say there's like IVC over here. I'm not sure. And then this line that you're able to see, this line that's coming down, that is a descending aorta. This line. Okay. That's what they've marked in this image, right? Okay, so and then we look for cardiomegaly. What is the criteria for cardiomegaly in a chest X-ray? Yeah, if it's more than 50% enlarged but it should be in PA view. So when you're looking at PA view, if the heart diameter, I guess, is more than 50% of the intrathoracic diameter, then it's said to be cardiomegaly. Yeah, cardiac diameter by thoracic diameter. So this is cardiomegaly. All right, it's more than 50% over here. Okay, cardiothoracic ratio. Yes, cardiothoracic ratio. Okay. Mm, so that is about cardiomegaly, like heart and mediastinum. We'll discuss more about heart stuff when I'm taking the heart things. I'm just nothing over here also. Why is there such a big gap? Okay. Mm, I mean, like chest X-rays with focus on the heart. Anyways, so ABC is over. Now we come to diaphragm. So in diaphragm, you basically look at the right hemidiaphragm, the left hemidiaphragm, the right costophrenic angle, the left costophrenic angle. Okay, in lateral view, you're able to see. So this is the diaphragm, the right diaphragm, the left diaphragm. The right diaphragm is slightly higher because of the liver. This is the right costophrenic angle, the left costophrenic angle. This is called the cardiophrenic angles, and this is the posterior costophrenic angles. It's seen on lateral view. Okay. Then you can see gastric bubble. Okay. Then you look for effusions, any pleural effusion or pericardial effusion. We'll talk about that in a few minutes. Okay, and then we look for lung fields. Basically, lung fields means over here. Okay, we'll come to that. Okay, so basically, based on where the pathology is located in a PA view and a lateral, you can kind of localize like where the pathology is. Okay, what part of the lung. So if the pathology is like just limited to this area, only this area, okay, then you can like with more surety say that it's the apical view. Okay, but if it's over here, it's kind of over here, you cannot with like a lot of surety say if it's the like if it's the upper lobe or the posterior lower lobe, I guess. Yeah, it can be anything. Okay, so this area basically confines to the upper lobe. Okay, right upper lobe. Then this is the right middle lobe. So the right lung has three lobes and the left lung has two lobes because the left lung has a lingula, right? Okay, so this is the right middle lobe. Okay, and the lower lobe actually comes like all the way here. So that's what I'm saying. Like you cannot really say if the pathology is somewhere over here, you cannot for sure say that if it's in the upper lobe or the lower lobe. It can be the upper lobe and lower lobe. For that, you need to see the lateral chest X-ray. If the pathology was over here, we'll know it's right upper lobe. If the pathology is on this side and then on this side, then it's the right lower lobe. Okay. The same thing you can also take on the left side. Left side also, the lower lobe is something like this. Okay, then and then the upper lobe is almost till here. Okay, so to say with surety in which lobe it is, more often than not you will need, okay, so that you can like see it in a 3D kind of way. All right. Okay, so basically if we just have PA view, we talk about lung zones. Okay, so based on the structure, we have divided the lung into. So if it's above the clavicle, it's called the apical zone. Okay. Then from the clavicle to the above the cardiac ciliate. So this is the cardiac ciliate where it's starting. So above that, like this zone, it's called the upper zone. Okay. Then below the level of the hilum, what is that? Anyway, okay, that is the mid zone. Okay, and the bases are the lower zones. All right. Like I think where the bifurcation happens, these are the hilar structures over here. So that is the the mid zones, and below that is the lower zone. All right. So there's apical zone, upper zone, mid zone, and lower zone. So if we just have PA view, we just talk about these things. We don't talk about lobes because we cannot say for sure. Yeah, I'm not talking. I was just waiting for someone to say okay or something. Anyways, okay. Sorry. Sorry. Yeah, okay, wait. Okay. Okay, so what do you guys see here? What are you guys able to see on this X-ray? Okay, so we're done with the approach. That's A, B, C, D, F, E, F is a. Now I think maybe for another 15-20 minutes, we'll just discuss a couple of X-rays, like clinical diagnosis, and then we'll close it. Okay. So what do you guys see in this X-ray? Which side is the pathology? Apical, which side? Both sides. Not sure. Um, this side. Can you see this? It's kind. Okay, so this is basically a pneumothorax. Okay, so pneumothorax, what you'll be able to see a translucent visceral pleural visceral translucent line that represents the visceral pleura. Are you guys able to see it over here? This translucent line. Okay, can you guys see? Yeah. Okay, so beyond this translucent line, there will be no lung markings. So you can see here the lung markings, kind of reticular stuff is there. Okay, but beyond this line, that over here there is no lung, right? This is all very clear. Okay. Okay. I'm just gonna clear everything up. Okay. Can you guys see? You guys are not able to see my cursor, right? Okay, that's the problem. So this is the visceral. This is the visceral pleural line. Okay, I'm just gonna point it with my arrow. I think. This one. Use yellow color. The highlighter. Not sure this one. There's a yellow color. Can you guys see? Maybe I'll just zoom in more. Can you guys see now? Yeah. Okay. That's good. Okay. So this is the so basically what has happened is there is air inside the pleural membrane. Okay, so this is where the air has come, or this whole area. Okay, this whole area. Okay, so this and so the lung has kind of pushed down over here. Okay, so you can see this translucent pleural line, and beyond that, you cannot see any lung markings. Like over here, you can see some lung markings, right? You can see some whitish stuff. Okay, but you cannot see over here. See even on this side. Okay, you're able to see lung markings. You're able to see lung markings not as clear as this side. Okay, but here you can see that there is lung markings over. Yeah, yeah, okay. But you're not able to see it over here. So this is pneumothorax basically, a visceral pleural line and no lung markings beyond that line. So that represents that there is air on this side. Okay, so that is basically pneumothorax. So in a simple pneumothorax, you'll be able to see these things. If there's a tension pneumothorax, you'll be also be able to see because of so much air accumulating inside the pleura. You'll be able to see tracheal deviation and deviation of the mediastinal structures also to the opposite side. Okay, let me see if I'm missing. Okay, so no lung markings, and this appears more radiolucent. Okay, then because sometimes pneumothorax can be due to any trauma or something, you can also see subcutaneous air in the subcutaneous tissues. That's subcutaneous emphysema. And you can also see air in the mediastinum. So that's pneumomediastinum. All right. So this is one. Okay. Now let's go to the next one. Okay. Now this is showing that what we could see in the previous one. Okay. All right. Okay, so this is the reading, PA view. Okay, yeah, we did all this. Left upper lobe pneumothorax. Okay, where's Junko sign? Not sure. Yeah, that's from Amos. Okay, Junko leaf sign. I don't know, dude. I'll read it and tell you. Okay, okay. What is this? What do you guys see here? Yeah, there is lung atelectasis. No, there is no effusion actually. It looks like an effusion, but it's not an effusion. At least oops, sorry. Okay. At least according to Amazon. Okay. Uh, Basically, what it says is that because of the atelectasis, the diaphragm kind of just comes upwards. Okay. So that's why the diaphragm looks more horizontal over here. And there's a pneumothorax over here. Not pneumonia. This is the lung. No, it's not considered consolidation. It's lung. If it was pneumonia, I think you were supposed to see air bronchogram stuff. Yeah, and there's a pneumothorax kind of thing over here. Okay. So that's the pneumothorax, and this is elevation of the diaphragm. Okay, so there are no bronchiovascular markings in this area. Okay. Then left hemidiaphragm is elevated due to loss of intrathoracic. Because the lungs have collapsed, there is loss of intrathoracic volume, and that's why the diaphragm is elevated. Okay. Okay. Now this one. This one. Can you guys see this one? One second, guys. Okay, I just need to reply to a text. Okay. Okay. Let's get back. Okay, so in here, prominent lobe margin. Where? Okay, so yeah, so this is again pneumothorax. Okay, translucent line. It's empty over here. But can you guys see this thing? Like there's a very deep what is this thing called? Costophrenic angle. Okay, yeah, very deep costophrenic recess. Okay, so this is called some sign. Forget it. I think it's called sulcus sign. Yeah, it's called sulcus sign. It's not written over here. So basically, a sulcus sign is sulcus sign is when the costophrenic recess. Actually, maybe this is not sulcus sign. I have another X-ray. This is but basically, what sulcus sign is that if the costophrenic recess is too deep, it is usually seen. It is not seen in A view. Actually, it is seen in AP view. No. Actually, it is seen when the patient is supine. So whatever view, but patient is when the patient is supine, then all the air collects into the basal and anterior regions. Okay, so that gives the sulcus sign. Okay. Yeah. Okay, so the patient has to be supine. That is the important thing. Okay, because usually for pneumothorax we take erect, but if you're taking the patient supine, then there will be a deep costophrenic recess. Okay, and that is called the sulcus sign. How are you going to differentiate between sulcus sign and? I will show you. There's an X-ray that will come. Okay. Okay. Then all right. Okay, so this is this. Okay. Mm, Yeah, you can. It can either be shriveled up or it can just be whitened. It can be either of those. We'll see. We'll see. Okay. Uh, mm, yeah, that is left name. That this okay. This actually has mediastinal shift. Kind of missed that. Okay. But yeah. Okay. So the trachea is shifted over here a little bit, and the heart is shifted, and everything else is also shifted. Okay. So this is actually a tension pneumothorax. Okay. Like you can see in this picture. It's tension pneumothorax. Okay. Wait, wait, wait. Okay. Okay. Okay, so you guys got this. This is tension pneumothorax because there's deviation of the mediastinal structures. What is this? Okay, yeah, this is the deep sulcus sign chest X-ray over here. Can you guys see? I mean, the pneumothorax is not that visible. I think it's over here. No, this is also pneumothorax. All of these are pneumothorax. Okay, we'll come to consolidation in some time. Okay. What I'm trying to show here is the deep sulcus sign. Okay. Yeah. The like the other findings are not that clear. Translucency and vertical line, but the sulcus sign is more prominent over here. Yeah, there might be something else. I'm not sure. Might be some other pathology. I just took this for the sulcus sign. Okay. Yeah. Okay. Now this one. Well, what do you guys see over here? What do you guys see over here in this X-ray? The vertebrae. Vertebrae are relatively okay. What is this? Okay, I was supposed to use yellow. What is this? And this. And yeah, you can see different like blackish spots coming in the middle, right? Here. Okay, so those are basically, yeah, okay. So basically this is air in the mediastinum, okay? Air in the mediastinum, okay? And this is air in the subcutaneous tissues over here. Can you see? Can you guys see? Okay. This is actually also a pneumothorax over here, I think. I'm forgetting where it was. This is the pneumothorax. Can you guys see this is the translucent line? And also they say that there's a rib fracture. I don't think I see that rib somewhere over here probably. Okay. Okay. But what I wanted to show is subcutaneous emphysema and mediastinum. Okay. And it looks like a pneumothorax over here. There is some line on the side. Feel like there's a line on the side. Okay. So yeah, I think they've marked it over here. Oh, there is. Okay. It's here. Okay. Forgot that there was answers here. Okay. Okay. So yeah. Um. Okay. I'll repeat it. Basically, can you can see like these streaks of translucency in the middle. Okay, this is basically air. If there's a streaks of translucent things in the middle over here, air in the mediastinum. Okay, so it's called pneumomediastinum. Over here in some subcutaneous tissues, over here you can see this translucent. Okay, so this is in the subcutaneous tissue. It's called subcutaneous emphysema. Okay, and yeah, pneumomediastinum. Okay, and then if you like see very subtle over here, it's very subtle, but it's there. There is like a visceral line over here. Okay, it's kind of indicating a pneumothorax. Okay, yeah. I think it's difficult because I'm streaming, but if you guys see the images for yourself, you'll be able to pick it better. So yeah, this is where it's showing marked. Okay? The pneumothorax, the emphysema, pneumomediastinum, right? So basically, patient had a rib fracture because of like the trauma and all. He has all. Yeah, I mean, Vorhap can also cause pneumomediastinum, but it's not always due to pneumothorax, right? Yeah. What was the number? The fracture? The fracture, as it's said over here, it says as a result of rib fracture, but they've not said like which rib. They've not even pointed out. So I'm not able to see actually. I don't know which rib is fractured over here. I think it's somewhere over here on the top because I'm not able to see any rib fracture. Yeah, it's okay. Okay, we're kind of going too long. I don't know what to do. Um, what is this? Yeah, this is the thing which is up. Okay, then. Okay, now we come to pleural effusions. I think we'll do pleural effusion and then we'll stop. Then we'll do whatever. Um. So yeah, what is this? I actually already said it. First of clavicle. Yeah, pleural effusion. So what are the things that help you let you know that it is? What are the features of a chest X-ray in pleural effusion? Oh wait, actually we didn't discuss. Otherwise we leave it. Okay. Well, how do you treat pneumothorax? Yeah, how do you treat pneumothorax? How do you treat tension pneumothorax? Yes. And where do we make it in case of tension pneumothorax? If we're doing a needle thoracostomy. Yeah, second rib in the midclavicular line. Okay, and if we're doing, if you're putting in a chest tube, if so basically if the patient is, if you're suspecting tension pneumothorax, if you're suspecting like if it's an emergency, like tension pneumothorax, you do a needle thoracostomy and then you put a chest tube. If the patient is relatively more stable and there's a large pneumothorax and you're going to put a chest tube, you put it in the yeah, fourth or fifth intercostal space in between the anterior axillary and mid axillary line. Yeah, yeah. Okay, so that's called the safe triangle. That's where you put it. Also, if a patient which you suspect has pneumothorax is unstable, like you're planning to give them, like put them on a ventilator or you're going to give them compressions, you're supposed to do emergency thoracostomy before you start ventilating. Because if you start ventilating, then a non would be converted into a tension unit. Okay, so before you start like ventilation and all, you're supposed to do um, thorax, like you're supposed to put a chest tube inside. Okay, so that was pneumothorax. So now effusion and pleural effusion, you basically you'll see loss of costophrenic angle. Okay, instead there will be a meniscus sign. Like over here, you can see it's like the fluid that accumulates in the pleural kind of um, goes up like that because of the some physics stuff. Okay, so you see a meniscus sign. Okay, okay. Um, let me just okay. Yeah. Okay, and then you might also be able to see fluids in the pleural in the fissures, accumulated in the fissure in between the heart fissure. And if there is a large volume of pleural effusion, you can see shift of the mediastinum. Okay. 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 So that is pleural effusion. Okay. So there might be shift of the mediastinum if the pleural effusion is very. All right. What is this? This is a very large mediastinum, pleural effusion. Okay, so basically the whole lung is whitened out, and there is a shift of the mediastinum, trachea, and the mediastinum. Okay, to the other side. Okay, all right. Okay, okay. So now what is the sex? This is for sputs. So you can see there's whitening out on one side. Huh, okay, but if like in this X-ray there was a massive pleural effusion, there was shift of the trachea to the other side, right? The trachea is shifted to the other side. But in this case, the trachea is shifted towards the side of. Mm, yeah, so this is atelectasis. Okay, so this is like lung collapse in a way. Okay, so that's why the lung has whitened out, but the trachea is shifted towards the side of the lesion. That's okay. All right. Hmm. Thank you, coffee. Okay, then we go to the next X-ray. What do you guys see in this one? No, come on. Okay, so this is a pleural effusion, but it's a loculated pleural effusion. That means it's confined between like certain lobes of the lung. Okay, so it doesn't. It kind of seems as if it's defying gravity, right? Like it's located in a weird place. Okay, this thing over here, exterior ribs. Okay, yeah. Okay, so how do we check if it's this is really a pleural? It could be TB or cancer. Okay, so how do we check? Okay, so what we do is we take a lateral decubitus X-ray. Okay, we take a lateral decubitus X-ray means basically we make the patient lie on one side, and in case of pleural effusion, we make the patient lie on the side of the pathology on this side. Okay. We can also take a lateral decubitus X-ray for pneumothorax. When we take a lateral decubitus X-ray for pneumothorax, we make the patient to lie on the opposite side. Means if this is the pathology, the patient will be lying this way. But in pleural effusion, we make the patient lie on the same side of the pneumothorax. Okay. And so, see, in this case, the pleural effusion just, actually, no, okay. In this case, the pleural effusion kind of goes this way. Okay, this is like a normal pleural effusion. This is not loculated. Okay, this is not loculated. If it was loculated, it won't go like this. I have no clue where the effusion, but it won't go. Okay, like it won't, like it'll defy gravity, so it won't come like this in a loculated pleural effusion. Okay, you guys understanding? Yeah, I think he did. Okay. Okay, so now what is this? Yeah. Okay, so now there's something called subpulmonic effusion. I think Poco had asked some doubt about this a few days ago. Okay, so basically, what a subpulmonic effusion is that there's fluid accumulation in between the lung and the pleura. Okay, so it's like it's below the lung. It's below the lung base. Okay, so if this is the lung base, it's below it, and it's up. Okay, and it's above the pleura. So it won't form a meniscus sign over here. Like this does not form a meniscus sign like this. Okay, it's how it's supposed to. It won't do that. Okay, um, in subpulmonic effusion, based on whether it's on the right side or whether it's on the left side, there'll be different findings. Okay, so in here, the diaphragm will appear more horizontal. Okay, it'll peak. Like see, in a normal diaphragm, it peaks early and then it goes down. Okay, this will peak later. Okay, it's kind of coming all the way till here, and there will be no meniscus sign. Okay, and it'll be raised, more raised than normal. So this is the right sided subpulmonic effusion. Okay, whereas on the left side, what you'll be able to see is this is what you apparently see as the border of the diaphragm, like the diaphragm margin. Okay, but then the gastric bubble is like very much below that. Okay, let me just clear so that you guys can see more clearly. Okay, so this is the, yeah, this is the dome of the diaphragm. Okay, and this is the dome of, I'm not using yellow, this is the dome of the diaphragm. Okay, and this is where you see the gastric bubble. Okay, so this is kind of actually the effusion. The left side is pulmonic effusion. It's below the lung base, but it is above the pleural margin. Okay, so this is called subpulmonic effusion. I think Poco had asked how do you differentiate between subpulmonic effusion and like pneumonia of the base of the lung. I think that's what he had asked. I think you can use this to differentiate. Okay. Then this is okay. Yeah. I'll stop after this. It's becoming too long now. I think we'll just do this, okay? And then we'll stop. Um, what is this X-ray? Yeah, what is this X-ray, guys? TB. Okay, what else? It also looks like a tumor. Okay, this is called the phantom tumor sign. Okay, so basically it looks like a tumor. There's some like consolidation kind of a thing. Okay, but it is actually just a pleural effusion within. Like this is the horizontal fissure of the right lung. Okay, so this is actually a pleural effusion within the heart. Okay, so that's why it looks like that. It looks like a tumor, so but it's not really a tumor. So it's a phantom tumor. Okay. Okay. So okay, so this is called a phantom tumor. All right. I think we'll stop. I think we should stop. All right. We'll just do the rest in the next class. Yeah. My dad asked me, so I think that's important. You should know it. Yeah. Thank you, guys. I mean, I actually didn't know like how long it will be, so I just did like that. So now if I have an idea, yeah. Okay, I'll just stop it now. Thank you.